So, hello, everyone. So I am Dr. Mo Lai from Myanmar Society of Radiation Oncology. This is the very first time for MISRO to participate in a FARO webinar. And we are very honored to participate to the event. And first of all, I would like to invite Dr. Imjai, who is the president of FARO, to say a greeting. And
hello, everyone. Did you hear me?
yes.
I'm pleased to welcome you to the 30th FARO webinar, which is organized by Myanmar Society for Radiation Oncology, or MSRO. This is also a part of a series of FARO webinar, which aims at providing knowledge to our FARO member countries for the benefit of cancer patients in Asia. Today's webinar topic is clinical experience on adjuvant hypofractionated radiotherapy of breast cancer. This webinar will fulfill your knowledge by Dr. Sumyat Thu from Yangon General Hospital. So thank you very much for your contribution to FARO. And I also thank for all the panelists from India, Myanmar, and also Korea. I would like to thank MSTRO and also IROS for the cooperation and make this webinar is international, consistent with the name and mandate of the FARO itself. I wish you all a very successful webinar. Thank you very much.
Thank you, Dr. Imjai, for greeting. And may I invite Professor Kincho Win, who is the president of MISRO, to give some words of greeting. Professor, please.
Hello, everyone. First of all, I would like to thank you to Professor Mo Lai for your kind invitation. And thanks for the Professor Imjai for your greetings. I am Professor Kincho Win, former head of the Department of Radiation Oncology and president of MISRO. We have been a member of FARO since 2019. It is my great pleasure to know our MISRO group are involved in different activities of FARO like scientific committee, education and training, research and leadership. Today is our very first time to participate in FARO ETC activities and looking forward to discuss about the clinical experience of Dr. Sumyat Thu.
I'm not sure if it was for everyone, but there was a significant echo when this was happening.
Thank you, Professor Kim, for your speech. And we are going to discuss about the ultra-hypofractionated radiotherapy. And there will be three panelists. Dr. Li Ang from Sorry, I'm muted. So we are going to discuss about the ultra-hypofractionated radiotherapy in the breast cancer. And there will be three panelists. Dr. Li Ao from MISRO, Dr. Rima from Tata Memorial Hospital, and Dr. Ji Suk Chen from Seoul, Korea, Yonsei Cancer Center. They are here with us for today's event. So shall we start a group photo before the presentation?
Yes, please. We'll take a group picture now. Dr. Kasmal, if you would take the picture, please.
Okay, I will start the countdown. And before we start, please make some time to take a group picture and open the video, please. I will start the countdown from 3. Or we take out from the first page. 3, 2, 1, cheese. Okay, we'll try the second page for our panelists. Please remain smiling. 3, 2, 1, cheese. Okay, thank you, professors and doctors. We will continue this webinar. Thank you.
Yes. Let's start the webinar. Dr. Sumiatu, please share your experience.
Thank you, Dr. Mo. Good evening, everyone. I am Dr. Sumiatu, radiation oncologist from Yangon General Hospital. I'm so glad that to be a today's speaker, and I also want to thank to my respected Professor Moline to thank for giving me a chance to share our clinical experience of Adjuvant Ultra-Hypofractionated Radiotherapy in early breast cancer at our center. Okay, let me share my screen. Can you see my screen? Yes.
Yes, please make a full screen.
Okay, firstly, I'm going to start my presentation with incidence of breast cancer. As all we already knew that breast cancer is the most common female cancer around the world and also in Myanmar. Our country-based data collection is still in progress. According to Global 2022, in Myanmar, breast cancer new cases was 7,644 cases and mortality was 6% in 2022. Regarding the management of breast cancer, it is multidisciplinary management, and radiation therapy is an integral part of this multidisciplinary management. Early breast cancer trialist collaborative group systemic confirmed that radiotherapy after surgery in early breast cancer reduce local regional recurrence and breast cancer death. In international management of early breast cancer is surgery with or without chemotherapy, with or without targeted therapy, with or without hormonal therapy, with or without radiotherapy. But in Myanmar, management of early breast cancer is surgery with or without chemotherapy, with or without targeted therapy, with or without hormonal therapy, and prolonged RD waiting time, and then radiotherapy. In modern decades, we use the histological regime 25 to 28 fraction after breast conserving surgeries or total mastectomy. But alpha-beta ratio of breast cancer is low, and breast cancer is one of the few malignancy where fraction size is high. And many randomized control trials confirm that there were equivalent efficacy and safety of hypofractionated radiotherapy in breast cancer. This is a flow chart of evolution of hypofractionation in breast cancer. In 1980, conventional fractionation. In 2009, study became UK standard regime, and 2020, ultra-hypofractionation. This is in international. In Myanmar, we started use the trial in 2011, and in 2024, we started consider to use ultra-hypofractionation to reduce our prolonged waiting time. Our developmental adjuvant ultra-hypofractionated radiotherapy was based on fast-forward trial, and it is the phase 3 randomized non-inferiority trial in UK, and it compared the 40 gray in 15 fraction with 26 gray in 5 fraction and 27 gray in 5 fraction. In 2020, the 5-year efficacy and late non-medical effect of fast-forward trial results came out, and it confirmed that 26-degree infiltration over 1 week is non-inferior to the standard 40-degree infiltration over 3 weeks for local tumor control and normal tissue effect up to 5 years in early breast cancers. I'd like to share about our experience of ultra-hypofractionation in early breast cancer at our center. Our developmental ultra-hypofractionated radiotherapy started from July 2022. Total patient was 20 patients. All were diagnosed with invasive carcinoma of breast with pathological T1 to 3 and 0 to 1 and 0 after mastectomy and axillary clearance at 2, level 2. We excluded ipsilateral microinvasive disease, past history of malignancy, AZ, skin cancer, carcinoma in situ, salvage try, or non-breast malignancy allow if treated with curative intent and at least 5 years or disease-free survival. Contralateral and previous ipsilateral breast cancer, including TCIS, regarding update or diagnosis. Dose resignation was 26-degree infiltration, 5.2 per fraction in 1 week. We used 3D or IMRD-based treatment planning. Beam energy was 6 MP or 10 MP. Patient was supine at reproducible position. We used the breastbone with M and reversible or patient underwent CT simulation with immobilization system with 5 millimeter slide thickness. We control the chest wall CTV according to Israel breast contouring guideline. Chest wall CTV encompass both surgical skin flat and underlying soft tissue. The deep fascia excluded underlying muscle and ribcage. Cranial border up to the level of caudal edge of the sternoclavicular joint. Caudal border is up to the contralateral breast shape disappear. Medial border is up to ipsilateral edge or sternal border. Lateral border is up to mid-axillary line. CTV to PTV margin was 10 millimeter for certain error and breathing. Post-mastectomy bullets was applied to all of the chest wall. Treatment verification included daily bottle imaging. These are the planning objectives. For lower dose limit, more than 95% of volume should receive 95% of prescribed dose. And for upper dose limit, less than 5% of volume should receive more than or equal to 105%. Less than 2% of volume should receive more than or equal to 107%. Global Tmax must be less than 110% of the prescribed dose. Organ as was ipsilateral lens and heart. For OER dose constraint, the agree of the ipsilateral lens volume must be less than 15% of ipsilateral lens volume. For heart dose constraint, the 7 degree of heart must be less than 5% of heart volume. The 1.5 degree of heart must be less than 30% of heart volume. This is the table showing patient characteristics. Majority of patients were between 50 to 60 years of age. And according to the size of primary tumor, majority are right-sided. About 75% of patients. Regarding pathological destaging, most of the patients were pathological T2. In pathological end staging, 75% of patients were N0 and the rest were N1. According to the hormonal status, most of the patients were ER positive, PR positive, and HER2 negative, which was 50% of patients, and none of the patients with triple negative were included. We review the patient for radiation toxicity to radiotherapy, and then weekly adjuvant to 1 year, and thereafter subsequently to next 1 year. This is a table showing acute skin toxicity of the patient. 50% of the patient presented with CTCAE grade 1 skin toxicity, and 45% was grade 0 and 5% was grade 2. Zero and 20% was grade 1 and 5% was grade 2. Radiotherapy, when patient presented SCF recurrence and land metastasis, no local regional recurrence and no distant metastasis in the remaining. No significant late toxicity was observed up to 2 years. As our country is resource limited, we don't have facility for respiratory motion management. Although planning objectives are described in previous slide, not all the plan have reached these objectives. These are the plan evaluation of regarding the upper dose limit. 80% of plan show that less than 5% of PTB volume receive more than 105%, and 20% of plan reveal that more than 5% of PTB volume receive more than 105%. Maximum percent of PTB volume receive more than 105% is up to 7%. And for your dose constraint, 70% of land show V8 grade or equilateral length it was less than 15%, and 30% of plans show that V8 grade or equilateral length was more than 15%. Maximum volume of V8 grade or equilateral length is up to 18%. In head dose constraint, all the plans show that V7 grade or had receive less than 5%. Regarding the V155 grade or had, most of the plans show that most of the plan reach the target range, but only 30% of the plan show that V155 grade or had received more than 30%. And maximum volume of V1.53 or had is up to 42%. This photo showing the 95% dose distribution or just for all PTB. And this photo showing the TBH or PTB, and you can see that you can see the 95% or PTB volume receive 96% of the prescribed dose. In this photo, you can see the 5% of PTB volume receive 106% of the prescribed dose. And this is the photo show that the 7 grade of heart receive 3.2% of heart volume. And this is the photo showing that the area of its lateral lens receive about 18% of its lateral lens volume. Although we have requirements and difficulty, Adjuvant Ultra-Hypofractionated Radiotherapy is still attracted to both radiation oncologists and patients because treatment time is short, that we can spare resources and reduce machine workload. And we can treat more patients than 3-week regime. So we can reduce the waiting list. And for patients, they do not have to go to hospital frequently so that it can reduce their transportation costs and therefore it is cost effective. That is why ultra-hypofractionated radiotherapy may be effective option in a resource-limited country like Myanmar. Thank you for your attention.
Thank you, Dr. Sunyatu, for sharing your clinical experience with the limited facility. And I would like to invite Dr. Liao. What would you like to comment more on this experience?
Hello, everyone. I am Dr. Liao from Yangon General Hospital, Yangon, Myanmar. In our country, breast cancer and cervical cancers are the most common cancer. The main problems are the increasing cancer patient with inadequate machine and limited resources. So we have alone are the waiting list for radiotherapy treatment. Regarding the breast cancer, we have a plan to change to ultra-hypofractionated radiotherapy in order to reduce the non-RD waiting list. We have never used the respiratory motion management device such as the respiratory gating method, deep inspiration breath hold technique, abdominal compression, and surface imaging. So we share this clinical experience with other countries. These suggestions for our experience.
Thank you, Dr. Liao. And Dr. Rima, what is your experience? But because your center is full of the facility and you may have so much experience with the ultra-hypofractionated adjuvant radiotherapy. So please, may I request some comments and suggestions for our center, like with the limited resource and your experience with the full facility?
Good afternoon, everyone. Thank you for inviting me for sharing our experience on ultra-hypofractionation. Our experience with ultra-hypofractionation actually started way back in 2014 or 15, when early results of UK FAST study were published. So the weekly once regimen rather than the daily 5 regimen. So the patients who were not able to take 15 radiation, either because of infirmity or due to logistical issues where they could not travel to the radiation center for 15 fractions, were treated with weekly once radiation. Or some patients who were really old and frail and could not travel daily for 15 radiations were also treated with this. And during the pandemic, essentially, that is why we were fairly ready to adopt the 5-fraction regimen. And for 2 years nearly, all patients of breast cancer who came to our hospital for radiation were treated with 5-fraction, whether it was weekly once or it was daily 5 treatment. So we have a vast clinical experience in the sense we have more than 2,000 patients treated to date with the 5-fraction regimen, of which more than 1,800 are non-metastatic cancers. So in our hospital, we use strict quality assurance in the sense that if a patient requires supraclavicular radiation along with the chest wall or breast radiation, we use only monoisocentric technique, so that there is absolutely no chance of having a match line fibrosis or brachial plexopathy. We also have a very standardized form of 3D CRT planning, and obviously over the years we've matured in IMRT planning as well. The important aspect for resource limited countries is in understanding the fact that if you can offer 40 grain 15 fraction, that's the moderately hypofractionated radiotherapy at your center, you can very well and easily offer even 5 fraction treatment, because the planning is absolutely not different. It's the same, unless you are planning inverse planning IMRT. So large majority of our patients have been planned with 3D CRT or what we call as field and field IMRT. So it is equally doable in any resource limited setting, as was the case in our hospital also. And during the pandemic, we were also challenged with the resources, because we had fewer staff for planning, fewer for executing. So our radiation therapists were also very few. So it was important at that point in time to incorporate 5 fraction regimen. What we also noticed is that we had nearly 100% compliance to treatment. That means even during the pandemic, less than 1 patient had actually dropped out of radiation midway through. And had we kept it as 15 fractions, more number of patients would have missed the treatment. So I feel that 5 fraction regimen is doable. And we've also had very good results. Very few patients, less than 5% of patients have grade 2 or higher toxicity, whether it is limited to the oropharyngeal mucosa or for that matter skin. And in terms of late toxicities, we have more than 800 patients who've completed 2 years now, and none of them have had a serious grade 3 events or more in terms of late toxicities. The only important aspect for people who start with ultra-hypofractionation, especially with daily 5 regimen, is that the acute toxicities don't come up at RT conclusion. They can come in a little later, say 2 to 3 weeks after finishing your radiotherapy. So that's just one thing to keep in mind, to keep the patient in the loop and tell them that if the toxicities increase, then to return back to the treatment. That's it.
Thank you, Dr. Rima, for sharing your knowledge. And Dr. Ji-Suk-Chan, what is your comments and opinion for us? Because with the previous presentation, we saw that although the plan objective is very good, we don't have the much facility, and so that we are too constrained way more than the plan objective. So what is your comments on that?
First of all, thanks for having me, and it's really a wonderful presentation, and also a very good comment from both other moderators. So first impression, rather than being hesitant and reluctant to a new technique, it's very good and fantastic to see that embracing a new technique. So first, I want to acknowledge that in Korea, our institution and Samsung Medical Institution, as far as I'm concerned, only two centers implemented 5 fractions fast forward regimen, for last 3-4 years, just because the first reason in Korea is the medical system. It's a fee for service, so adopting a 5 fraction regimen is, which means that it's reducing the revenue of the hospital. So that's the main reason that other hospitals is reluctant to embrace it. And the second reason is there's still a lot of people who have uncomfortable with using of high dose per fractions, which is quite surprising. And I've been working in a BC cancer in Canada for the last 2 years, so I also know the situation in North America, and I can see like in Canada, like the 5-fraction fast forward is already a standard of in almost many centers, but in America, like in an academic center, like increasingly used 5-fraction regimen, but there's in a private hospital, just like in Korea, they're still very hesitant. So that's first of all the first comments that I want to do, and also another characteristic of practice in Korea is nearly 100% of fast forward regimen we are using VMAT planning. So which is just not because of the scientific evidence at all, but it's because of like IMRT has been reimbursed, and which is in since 2014 in breast cancer. So because it's available, and then we feel because of the auto contouring, all the resources, so we feel comfortable doing IMRT than 3D. So that's the reason. So I don't want to put more emphasis on using an IMRT or VMAT. I think like a tangent technique or field-in-field technique, it's fine, and so there's no need for doing a far advanced technique. So I think like rather than a advanced technique, DIBH or CPAP or this kind of like like respiration holding breathing holding system is something that we need. And then I want to introduce that the two things that because DIBH is sometimes labor intensive and resource intensive. So another alternative is introduced recently, first invented by Israel Group, which is a CPAP. CPAP is something instruments that used for sleep apnea, but they applied it to the breast patients, and then they have a very similar effect. And which is CPAP is really cheap and then very easy to access. So our institutions, because of the patient workload, we switched from DIBH to CPAP since 2019, and then it's amazing. So all the effect is very similar, and then and it's already so I think that is another suggestions. So in terms of the presentations, I just have 3 comments and then questions. The first one is like in a fast forward trial, these patients are the patients not undergoing regional node radiations. So so I assume most of the patients were breast conservation surgery, not the mastectomy. There might be mastectomy, but no but not regional node radiations. But I saw the slides that there are many patients with a mastectomy. So so that is the one question. So is there is the mastectomy is more common? So sometimes like a very early stage, maybe post-mastectomy radiation is maybe not necessary. So we have to like look into that first, and then so also I noticed that there is the bolus was used in. I assume that most of the patient was bolus was applied, but in our practice we try to de-escalate our treatments according to the risk strategy, because I assume that these patients are very early stage because regional node were not indicated. And then the recent international consensus recommend, unless T4 disease, bolus was not recommended. So I just want to give some comments about the necessity of the bolus in these patients. And then also the last question is about the boost. Because of the mastectomy patients, maybe boost was not indicated in most cases, but the most polarizing and then controversial issues around the fast forward is about the use of boost, because that trial is not necessarily addressing the issues of the boost dose. So 5 fraction or 3 or 8 fractions, like conventional boost dose, was used in a fast forward trial. So this trial didn't give a great answer to how to optimize and use the boost dose. So I also want to ask to Rima, Dr. Pathak, about how do you integrate the boost dose in your 5 fraction regimen. So in our practice, like it's varied across the physicians. I prefer SIB, but there's no evidence of SIB yet. And other professor, they use like a 5 fraction, 8 fraction, like sometimes 16 fractions. So the boost is also another issue. So yeah, that's my comments.
Thank you, Dr. Ji-Suk Chang, for your extensive knowledge. So most of our patients have undergone total mastectomy. Very rarely breast conserving. Usually we practice in our country, we practice the total mastectomy and axillary dissection. So the adjuvant breast radiotherapy to the chest wall is very difficult. Usually we use 15 fraction. So this is to reduce that, because of the imbalance of the radiotherapy machine and the patient load, we need to change to ultra-hypo for some cases, just like this breast cancer. So Dr. Injai, what would you like to add some more?
No, I just want to listen the answer from Dr. Pathak about the Chang's question. Do you have any comment, Dr. Pathak?
So, contrary to what is the practice in Korea regarding IMRT, we majority of our patients are treated with field-in-field IMRT or 3D CRT, and that was also a sort of a prerequisite for participation in fast-forward study. Participants or centers had to take special permission if they were going to use VMAT or inverse planning IMRT for fast forward. The one comment that I need to make is that it's not entirely correct that the fast forward study did not have regional nodal irradiation. There was a nodal sub-study and the results of which are published as an abstract in the ESTO 2022. So the nodal sub-study also showed that regional nodal irradiation, barring IMN-RT. So if you were to give supraclav or axillary radiation, that's safe with 26 grain 5 fraction with no long-term toxicity in terms of arm edema or arm restriction seen at around 3 years. So 3-year toxicity update is present, and we also presented our largest experience of nearly 1,000 patients of regional nodal irradiation at ASTRO in 2023 last year. So it is safe if patients had to undergo regional lymph nodal irradiation. That is keeping in mind the kind of radiotherapy that we practice over here. So like I said, that if there was a patient who required supraclavicular radiation, we strongly advocate using a match line technique such as monoisocentric technique, so that there is no overlap between the supraclav and the tangential radiation. So that's part one. And I agree with Dr. Ji-Suk Chang regarding the controversy surrounding the, if in fast forward, they wanted to reduce the overall treatment time to 5 days, they should have made provision for accelerating the boost as well. However, they did not do that because they did not want any confounding factors with SIB. So that was the main criticism for the boost technique. Now, coming to our experience, so because majority of our patients were treated during the pandemic, and as rightly said and experienced by all, we really wanted our patients to have fewer hospital visits. 99% of our patients during the pandemic had received simultaneous integrated boost. So if we were treating patients with daily 5 regimen, that is 26 gray in 5 fraction, our boost was 32 gray in 5 fraction. And if our patients were undergoing the radiation weekly once, then our doses were 28.5 gray in 5 fraction with a SIB dose of 33 gray in 5 fraction. So this is what we used. However, coming to 2023, when we adopted using UHFRT as a standard regimen, just like in many Canadian hospitals, so for all those that are eligible for fast forward study, so if they match the eligibility criteria, that is T1 to T3 and N0 to N1, these patients now undergo a fast forward regimen treatment at our hospital, and they are being offered sequential boost. To begin with, our sequential boost dose has always been 12.5 gray in 5 fraction, and we have retained that for simplicity. But I agree that there is a lot of controversy surrounding the boost, and a randomized study is needed to try and address what is the appropriate boost dose, or in sequential or in simultaneous setting. And no studies as of now answering that. There is a HIPOT study which is ongoing, but that also gives you an option of doing simultaneous integrated boost. So only time will tell once the accrual has finished how many underwent a simultaneous treatment versus how many underwent a sequential treatment. I hope that answers most of your questions. If I've missed out something, you can ask again.
I think like that is fantastic. Like I also put some link in a chat room that maybe like that is the abstract of that you mentioned. Maybe the abstract.
Yeah, by Duncan Wheatley.
And there is also ongoing trial in Canada, like testing, randomizing the region, like a fast forward regional and moderate hypofractionated regional, which is like conducted by Team Wellen, which is the trial called RT-RUN. And also I personally asked all the like physicians who enroll the patients, and then they feel 26 gray regional node is perfectly fine and comfortable. So and also another thing is in this upcoming Astro, like the RT-CHOM trial will be presented, which is like comparing moderate hypofractions with conventional in a reconstruction breast patients. But maybe the result is embargo, but like there is a positive will be a positive result, I assume, in a moderate hypofractions, and then the next step will be they're testing the hypofraction moderate, like a fast forward regimen in a even in a reconstruction setting in the upcoming the subsequent trial. So I think like a fast forward is has a very expendable and then have a very promising thing. So yeah.
I agree, and I feel that this is something that everyone, just like everyone had to move from conventionally fractionated to at least moderately hypofractionated regimen throughout the world. Slowly and steadily, people will have to come to terms with the fact whether they are being paid fee for service or bundled payment, that ultra-hypofractionated regimen is the way forward. So slowly and steadily, even patients are asking as to why I'm being offered 15 fraction when at other institutes even 5 fraction is being offered. So more awareness, and there needs to be changes that have been recommended in the fee structure. Also, something called as bundled payments are what is recommended for the outcome, rather than having everything be calculated by fractions. So in the long term, that should be implemented for people to really switch over to what is evidence-based.
Thank you. Thank you all the panelists for sharing the extensive experience and knowledge. And now I think this is the floor is open for questions and answer. So there are 3 questions I see. One is from, not mentioned about the about the participant. It said, thanks for the presentation, Dr. Subiatu. I would like to ask one question regarding your trial. One patient had supraclavicular fossa recurrence and lung metastasis, which is the ipsilateral or contralateral supraclavicular fossa recurrence. Dr. Subiatu, would you like to?
One patient presented with ipsilateral recurrence and metastasis, non-contralateral.
So another question is, thank you for the informative presentation. Did you observe any symptomatic toxicity of the lungs? Because in your experience, lung dose is more than the planned objective.
Although the land dose constraint was a little bit more than planned objective, we didn't observe any symptomatic like land toxicity up to 2 years. Thank you.
And that is also true with our cohort. Even in our cohort where we've used IMRT or VMAT in some patients, the constraints that are published by the fast forward group for 3D CRT are not applicable to the IMRT cohort. And the higher low volume doses or low doses did not really transpire symptomatic radiation pneumonitis in any of our patients out of more than 2,000. So that's fairly reassuring in many ways. And in fact, we also have more than 200 patients who've received radiation to the internal mammary nodes, where obviously the lung and heart doses are much higher than when you're treating patients without the IMC irradiation. And even in those cases, we've not seen any late cardiac toxicity or increased cardiac death from radiation. So again, very reassuring.
Yeah, I totally agree. And honestly, there's no good long dose constraint in breast RT. So I think we are extrapolate the dose constraint and dose objective from lung cancer radiations. But like a lung radiotherapy has a very high dose in a lung area. So and their threshold might be different from breast radiation therapy. So our group, 5 years ago, we look our 2,000 patients, like a mixed cohort of like a IMRT and a 3D, and then we also find that like a low dose area is not clinically relevant to the in a clinical toxicity, and we found like a V20 is really important, and we can use a different cutoff because when we look to the like a grade 2, grade 3 toxicity of like a 10% or 15%, we are not looking the kind of high toxicity rate. We are looking like a less than 5%, less than 3%. So in terms of this kind of like a sense, in this context, we are now using V20 of like a less than 15% of and we are sure that when we met this objective, we think like a radiation pneumonitis can be a less than 3% or less than 1%. And also, one thing that we are currently investigating is secondary lung cancer, which is overlooked for long decades, but which is when the patients live like more than 10 years, secondary lung cancer can be quite clinically relevant in these patients. So, and then there's this modeling study that like a mean lung dose is correlated to the secondary lung cancer. So regardless of the low dose area, maybe it's good to reduce the overall mean lung dose if the patient had a very good survivor prognosis, like who will have a long-term survivor. So
I actually completely hear that we don't have any good lung constraint, and we've been using the constraints published by the thoracic oncology. The funny part is that they use these constraints for total lung, whereas we use it for ipsilateral lung. So we already are naturally halving the risk by just using it in one lung, and over and above, obviously our doses are much lower. So very blessed in that sense that we don't see radiation pneumonitis. The very fact that you are trying to see the relevance of secondary lung cancers because of the low dose fill in the lung and the higher mean lung doses with inverse planning IMRT, it is important to understand that 3D CRT gives you the best conformity for the lowest price you pay in terms of OAR doses. And which is why if patients are eligible and are suitable for treatment with 3D CRT, that is and should be the first preferred tech.
Thank you, Dr. Rima. So there is another question from Stephen Lowell. So, any experience treating the patients with reconstruction? How was the cosmetic outcome and toxicity? And also any experience with the high tangents? So I think the panelists can answer the questions.
So unfortunately, even during the pandemic, we had a conflicting trial which was running between a conventionally fractionated treatment versus moderately hypofractionated treatment for reconstruction patients. And therefore, I don't have an experience or large enough experience, just 2 patients who've been treated with 5 fractions, both of them were doing fine. But 2 patients mean nothing. So unfortunately, I'm not the right person to answer this. Maybe Jisuk Chang has more experience.
No, I also don't have much experience. I feel like 5 fraction is really safe personally, but because of the lack of evidence, I didn't really use it in a reconstruction setting, in an adjuvant setting. But because of the ECOG trial in a metastatic setting, if the patients need some adjuvant radiation in a metastatic setting, I personally recommend and use 5 fraction regimen, adjuvant regimen in a metastatic setting. And then there were several a reconstruction patient, and then even though it's anecdotal and then a 4-5 cases, they're all cosmetically fine, and there's no toxicity. So I feel 40 grade 15 fraction is really similar and in terms of toxicity and cosmesis compared to a fast 4 regimen. So that's my personal takeaway.
Thank you, Dr. Rima and Dr. Chang. So there is the last question from Fanny Kusel. Dr. Su, thank you for the presentation. Do you have any suggestion, want to choose 1 fraction daily or to make it weekly? So can you answer, or I think it can be better answered by the panelist?
Yeah, I also have this kind of a consideration in my clinic, and so the first thing is weekly regimen has a longer follow-up, so maybe more confidence. But I cater to patient preference, because sometimes patients prefer every treatment in 1 week, but sometimes patients prefer once they want to travel weekly. So it's just based on patient preference. I feel 2 regimen has a very similar and same toxicity and local control rate. So I have very flexibility of using both regimens.
So I have a slightly different take on that. While FAST has longer follow-up of 10 years published in 2020, FAST study was not designed to look for whether the recurrences were similar. It was chiefly designed to look for the alpha or beta value of breast tissue, which it did very well. And in those 900 patients, we could answer that. But to extrapolate the results from UK FAST study into clinical practice is slightly tricky for a simple reason. Majority of the patients used in the UK FAST study, if you see the eligibility criteria, in today's day and age, by the Prime 2 study, you could avoid radiotherapy in those patients. So they were fairly low-risk patients, elderly, screen-detected tumors, and none of them merit giving a boost. So you can understand how low the recurrence risk was in that cohort. Now, to apply that same result to someone who's locally advanced or someone requiring nodal irradiation is a little tricky because you don't know whether that dose is enough or not. But having said that, we've used it. And we are just waiting for it for maturity of our results by another 3 or 4 months, and then we should be able to tell whether UK Fast Forward also works in locally advanced setting as well. In terms of how do we select? Of course, patient preference is priority, but over and above, if a patient is elderly and meets more of the early breast criteria, then we prefer treatment with UK fast regimen, that is weekly once. But if it's a young premenopausal lady with nodal irradiation, then the evidence points towards using fast forward over UK fast study, despite the lower follow-up in the fast forward regimen. So by evidence, if you go to see, UK Fast Forward was a more pragmatic study and was designed to be rolled out in clinics, whereas the UK Fast, even though few people talk about it, was not designed to be rolled out in clinics. But we can correlate the outcomes and then finally use it in our clinics the way we are using it.
Thank you, Dr. Rima and Dr. Chan. So is there any questions? Comments? No? If there is no questions, I think the time is ended now. So thank you all the panelists and participants for sharing your extensive knowledge. It is a high time for the radiotherapy service to implement the hypofractionation, especially in resource-limited centers like us. Hypofractionation provides the potential benefits in terms of cost and convenience for the patients. Today, we can share the experience and knowledge on hypofractionation. I hope all the participants gain the experience and knowledge to implement the hypofractionation at their respective countries with the available facilities. So we would like to express our gratitude to FARO ETC committee and organizers for this great event. And I also would like to extend our gratitude to all the participants for joining this webinar. Okay. So, Dr. Injal?
Yeah, you can close.
Yeah.
Thank you very much for joining today. Thank you, MSTRO and also IROS for this collaboration and also all the panelists. Thank you.
Hope to see you all in next webinars.
Yes, next month.
Thank you.
Dr. Tomo?
Oh yeah,
Dr.
Tomo is here. Tomo, say something.
Oh, thank you for this great webinar. I think it was wonderful, and thank you to all the speakers and panelists, and including all the staff from Nostro, because I miss visiting your country. Thank you. Great work.
Yeah.
Thank you.
Oh, yeah.
Bye.
Thank you. Bye.
Thank you.
Bye.